Okay, so welcome everyone to the next Division of Psychiatry special lecture series. So I'm delighted today to introduce Professor Anne Duffy, who is a professor of psychiatry at Queen's University, Kingston in Canada, but also a visiting professor at the University of Oxford. As many of you will know, Anne has a long-standing clinical and research interest in the early course of mental illness, particularly bipolar disorder. And this is in children, I guess, at high risk of mental illness through cohort studies. But also she has an interest in university student mental health, students being as they are going through a maximum period of risk for the onset of things like depression and bipolar and psychosis. So the title of Professor Duffy's talk today is Mapping the Trajectory of Psychopathology in Youth at Familial High Risk and in University Students. So a very warm welcome, Anne. Thank you for joining us. I'm really looking forward to your talk, and hopefully we can have some discussion afterwards. So I'd encourage people to use the Q&A box, not the chat box, as you go through, and I can moderate some of the questions at the end. But thanks, Anne. Over to you.
Great, thank you very much. Thanks everyone for joining us, and thank you, Daniel, for this invitation. It's a real pleasure to provide this lecture this afternoon. So I'm going to be focusing on the onset of mental health problems and disorders in young people, and really talking about two complementary approaches to studying that question. And I'd just like to acknowledge that the work that I'm going to be speaking about has been funded by various national and international grants, as well as philanthropic funds. So I'm just going to start with a brief background. Why are youth mental health disorders important? And then move on to the two complementary cohort studies in children at familial risk, and also more recently in the university student population. So we know that mental disorders and substance use disorders in children and youth account for a large proportion of disability and years of life lost. So this is the Global Burden of Disease World Health Organization population study, and we know from this, for example, that anxiety disorders and depressive disorders already account for a large proportion of disability adjusted life years, even into early childhood, moving into adolescence, and then followed closely by substance use disorders later on in adolescence and early adulthood. We also know from studies like the Dunedin study, for example, that the majority of mental disorders in adulthood actually emerge or onset in adolescence or early adulthood. So this is really a peak period of risk for the onset of these disorders, and they're already causing a great deal of morbidity and mortality. And we know, for example, mortality is also attributable to a higher risk of suicide. Now, this is the Adult Psychiatric Morbidity Survey data showing that in terms of common mental disorders in England, young people these days are marginally more at risk than in previous generations for anxiety and depressive disorders, whilst the risk of bipolar disorder and schizophrenia has generally maintained the same rate. These more anxiety and depressive disorders have shown an increase. And this is largely driven by females. Similarly, there's been an increase more recently in self-harm, again driven by females, whereas overall, the suicide rate has decreased and then started to increase again. And of course, it's the reverse, where more males are likely to complete a suicide, threefold more likely, although there's quite a variation in suicide completion rates in different nations within the United Kingdom. Now, the sort of working model is gene by environment. So this is Craddock and Owen's model. I really like to show this because it really gets to the complexity of the situation. So why haven't we discovered the genes for? Well, it's complicated, right? So we inherit certain DNA variants. Probably multiple variants contribute to risk, and they do so by influencing many overlapping and complex biological and neurological systems, which in of themselves are influenced by environmental exposures. And then that together maps on to symptom level psychopathology, which we cluster or recognize in patterns to form our diagnoses. And there's a lot of overlap in symptomatology between different diagnoses, and there's not a lot of quote unquote, clear water between those distinctions. So it's difficult and complex to understand, especially when our diagnoses are quite heterogeneous. So if we want to understand the onset of psychiatric illness or mental disorders, one approach is studying children at confirmed familial risk. And that's because of the high estimated heritability, or the amount of that risk that's attributable to genetic factors. And bipolar disorder is one such illness that's useful to think about and look at in these ways because of the high estimated heritability. And of course, we know that this is quite interestingly an illness of alternating polarity, so both depressive as well as manic or hypomanic episodes, and has long been associated with creativity. And whilst there's some evidence that certain psychotic forms are more neurodevelopmental in origins, these are different from classical neurodevelopmental illnesses in many respects. We know that already early in the course, there's significant burden of illness and increased risk due to suicide. So in other words, this is a highly heritable illness that runs in families, onsets early in life, and already has a significant burden of illness. So it's a ripe candidate for familial at-risk studies. We also know that the peak age of onset for the so-called early onset form really starts in adolescence and climbs to early adulthood. And so this is really the peak period of risk that you want to study young people at confirmed familial risk through. And this is Danish registration data, just proving the point that, the risk if you have only no parent identified as having bipolar disorder is negligible, but increases with each parent. So here's 5% with one parent, 25% over a lifetime with two parents. And if you expand the phenotype in the child to include depression, the risk increases even further. Of note, this is Danish population data, as I said, or Danish registry data for patients involved in the healthcare system in Denmark. And you can see that you really don't see the risk until later in adolescence. Now, when I started out in my residency training, we used to say things like, well, there's a several-fold increased risk if you have a parent or a first-degree relative identified with bipolar disorder of developing the illness. But we knew that that was really quite inadequate given the fact that there was quite variability between individual families. So in one family, it could look almost like a pseudo-dominant trait, whereas in other families, it could look more sporadic. And so we really needed to titrate that risk assessment to the individual person and family. But we didn't have the data. And the other thing to remember about psychiatric illnesses is that they tend to present themselves differently in different people, even within the same family. So there's a different pattern and severity of symptoms between patients who share the same disorder. So this genetic and phenotypic heterogeneity is a conundrum for research because it's really hard to find a signal with all the noise. And so my mentor, actually, who I trained with in psychiatry in Ottawa, Paul Groff, had developed a strategy using prophylactic or long-term treatment as a way to identify more homogeneous subgroups that then would have characteristic developmental history, family history, and treatment response. And so, for example, we would talk about classical manic depressive illness that responded to lithium versus more psychotic spectrum illness that didn't preferentially respond to lithium as a prophylactic agent, and those patients did better on antipsychotic monotherapy, for example. So this is the original data sheet from Bastrop and Skow's lithium prophylaxis trial, and it really illustrates a number of really important points. One is which, when they start lithium, you can see these episodes of different polarities stop in people who respond to lithium. So, and if you wait past the cycle length, so here, several episodes a year, every year, and then on lithium, nothing in one minor episode, then you can say, well, this person looks like a lithium responder, as opposed to other patients who tried lithium but continued on to either have episodes or to have no effect. And the other thing to notice here is the fact that in those who responded to lithium, the predominance of their mood episodes was depression and not, so So that brings us to the study. So when I was training and I was helping out with the interviews of these adult relatives of bipolar patients for genetic studies, and these were the kinds of pedigrees that we were working with, looking for the genes for bipolar disorder. I was also training as a child and adolescent psychiatrist, and the relatives kept asking me, what did I think the risk was to their children? And of course, we didn't know. And so I started the study as a kind of one-year postdoc with Paul Groff, and I was to interview, blind to the nature of the parent's illness, the children. And we took all comers age 5 to 25 because that was the way the families actually were formulated, and we'd have enough children to interview. And that also covered the period of risk. So this started out as a cross-sectional descriptive study, comparing and contrasting psychopathology in the clinical course in children of lithium-responsive bipolar parents and children that failed 2 adequate trials of lithium. So they were lithium non-responders. I ended up staying for now over 25 years, and early in, we decided, of course, this needed to be a longitudinal study, and we would add a control group of kids from parents or families where both parents were well. The aims of the study were to describe the onset of illness in these high-risk children, to explore mechanisms that might be important in progressing the illness, and to identify opportunities for prevention and early intervention, and then to come back to this original question of improving risk prediction for individual children. So we found things we didn't expect. So one of the things we found was that the kids of lithium responders looked very much like controls. They either were normal in their early childhood functioning or gifted. That was in their socialization, their academics. There was no major motor deficits or cognitive deficits. Whereas the children of lithium non-responders did have a higher proportion of kind of neurodevelopmental presentations. This has been replicated in the VIA-7 study in Denmark, where they're looking at children at familial risk of bipolar disorder and schizophrenia. And looking at cognitive functioning, for example, you can see that the children at risk for schizophrenia fall below normal, whereas the children at risk for bipolar disorder look very much like controls. We also found actually a variety of disorders in the children at risk for bipolar disorder in both high-risk groups, and that was news to us. We didn't expect to find that. So anxiety disorders, sleep disorders. And in the kids of psychotic spectrum or lithium non-responsive bipolar disorder parents, we also found ADHD, learning difficulties, and cluster A traits. So very much like children of schizophrenic parents, for example. This again has been replicated by other studies, including the VIA-7 study, where they showed that children of bipolar parents tended to have internalizing disorders, so anxiety, stress, and adjustment, which is what we found, whereas the kids at risk for schizophrenia were the ones that tended to have disruptive behavior disorders and ADHD. Over time, what we realized was that this variety of disorders was coalescing. So if we think about Michael Rudder's developmental psychopathology approach, which also inspired the study, I should say I took an elective as a medical student and worked at the Maudsley and met Michael Rudder and heard him talking about developmental psychopathology. So I think that informed my thinking here. So we saw this evolution towards mood disorders as we followed these children forward over time in development. And this was replicated subsequently by the Dutch high-risk study, where they saw the same kind of movement in a much more elegant, I should say, diagram. So it was interesting to me. I was in a conundrum because I was trying to think how to describe the differences between the high-risk subgroups, because when you add up their lifetime diagnoses, they didn't look that different other than these kind of cluster A traits and sort of neurodevelopmental presentations. But what was really strikingly different as well was the clinical course. So the kids of classical manic depressive patients who responded to lithium had an episodic presentation of psychopathology that spontaneously remitted, whereas the children of the more psychotic spectrum lithium non-responding parents had more kind of chronic fluctuating layering psychopathology. It just never remitted. So we term this sequential versus concurrent comorbidity to try to get at the differences between the two subgroups. We were also able to show that in terms of the onset, it wasn't that these anxiety disorders were kind of like a prodrome or very close in time prelude to an onset of a depressive disorder. Rather, these were years earlier and predicted the onset of mood disorders. So you could see that the risk of a mood disorder in those with a pre-existing anxiety disorder was 2.5-fold that of high-risk offspring without that preceding anxiety disorder. What we also found, and at the time this was surprising, was the preponderance, or predominance, I should say, of depressive episodes in the early course. So of the high-risk offspring who had a mood disorder diagnosis, you could see that the first episodes tended mostly to be depressive in nature. And we didn't see any major mood episodes prior to age 10. And then once they started, they tended to recur. So this was very interesting because this to me didn't kind of resonate with what we know about unipolar depression simple, because it onsets later, it doesn't have that high recurrence rate. And then the episodic course of the antecedent psychopathology seemed to say this was really a bipolar predisposition. And once we had, fast forward to 2014, once we had enough children now in the study observed long enough, we could actually, I was working with a very talented mathematician who now is a junior professor at the University of Toronto. Anyway, he was a grad student and he used multi-state models to test this hypothesis as to this progressive movement through these stage-like phases of illness, and was able to show it wasn't sort of chaotic and it wasn't jumping, it was more sequential, so that you didn't have to have these antecedents, but once you joined the model, you tended to have a forward motion sequence through. So it seemed like a progression of the illness, but not in a progressive declining sense, just in an evolving of the psychopathology of the form thrust of the illness. And we also continue to show that the nature of the early antecedents were much broader in the children of lithium non-responders compared to responders. Now, happily, these findings were replicated across the world, which I think is unusual somewhat for psychiatry. So we were able to show that actually most children did not develop bipolar disorder by age 25 or 30. Depression was actually more common, but if they did develop bipolar disorder, it always debuted with, or not always, but mostly often debuted with depression in mid-adolescence. And that the age of onset of meeting full criteria for bipolar 1 or 2 disorder was late adolescence. And this was quite controversial at the time, but I think is now well accepted, that we did not see any of the so-called prepubertal manic phenotype in our high-risk offspring. And that created a lot of controversy because these were kids at specific genetic risk, highly selected families with high penetrance, and we didn't see this early onset, prepubertal mania. Now, happily, other people also made that observation. So the Dutch study saw no cases. Eglin's study in the Amish population saw no prepubertal cases. And other studies found very few. And when I spoke to Martin Preisig about the Swiss study, he said actually he went back and looked at, this was a structured interview, epidemiological style study, not a clinical interview like ours or the Dutch study. And he found that 5 out of the 6 cases that met criteria based on a structured interview actually were in the context of domestic trauma. So this research was very important for that first aid, mapping the onset of the disorder over development, and also, potentially providing us a refined framework to think about hanging other studies onto it to understand the underlying pathophysiology. But it also helped answer back to some of the controversies in the field, like, did these 4 to 5-year-olds who had pervasive developmental disorder, who were extremely dysregulated in their behavior with extreme irritability and explosive temper, was that really an early form of bipolar disorder? And I think most people would conclude, no, it probably is not related to bipolar disorder. And I like Gay Carlson's comment in the New England Journal, which this is maybe better called pediatric mental health care dysfunctional disorder, because some of the attribution from some of these groups has been, well, these children need a diagnostic home. Of course, well, I would argue that a cornerstone of medicine is accurate diagnosis, and it's actually harmful to diagnose people with something if it really doesn't fit. And then of course they end up getting medicated, potentially unnecessarily as well. And I really appreciate Kendler's comment in 2016 that we just cannot use the DSM alone as the basis for a diagnosis, especially in young people. We have to take a proper clinical history, clinical assessment, put that child in their social context and understand their clinical course, their developmental psychopathology, and of course, look at the lens of family history. So as we continued the high-risk study further, and it was a dynamic cohort study, so we were adding children as they became available and following them forward. We also started to look at clinically significant and clinically assessed symptoms. And this is an important point too, because self-reported symptoms are not the same as clinically assessed, clinically significant symptoms. And so when we looked at, for example, using the hypomanic checklist to self-report, the controls had higher rates of hypomanic symptoms than the high-risk kids. But when we looked at, so obviously they didn't have hypomanic symptoms, the controls, we didn't diagnose a single case of bipolar disorder in the controls, but they were essentially conceptualizing normal adolescence as exciting and mood lability and everything else. But when we clinically assessed hypomanic symptoms and saw that they were a definite change from usual, but didn't quite meet threshold criteria for diagnosis, these clinically assessed symptoms were predictive of recurrent mood disorder in these high-risk kids. Over time, we continued to see bipolar disorder onset, but not only starting in adolescence in both high-risk subgroups, and interestingly, major depression in the high-risk cohort onset much earlier than in the controls, but only in age 20 did we actually start to see major depression onset in controls, which is what we would expect from the literature, right? So the median age of onset of bipolar disorder in our cohort was 20, and the median age of onset of depressive disorder, was 16, but major depression was 17. And even though depressive disorders started to onset in controls, you can see that the age of onset was much later. When we looked again at the polarity of the first 5 mood episodes in those high-risk offspring who now met criteria for bipolar disorder, what we found again was the predominance of depression. So this is the proportion of depressive episodes, but especially in the kids of lithium responders. So that's more class. So it's almost like the clinical course breeds true from parent to child. And psychotic symptoms were in the minority, not common in the episodes, but more common in the lithium non-responders. So this allowed us to refine this model, which could be a kind of conceptual framework, which gets at aims 2 and 3, which was the idea of where can we look to intervene and make a difference in this progression, and also could we improve individualized risk. So with that in mind, I'll just speed through here in terms of ways we've tried to address that. So one of the things that we found was the earliest point of prevention intervention would be with the parent. So based on our observations that the more exposure to unstable illness in the parent that the offspring experience, the higher the risk of mood disorder, and particularly from 0 to 2 years of age. Stephen Jones in Lancaster had developed an integrated digital intervention targeting parents of bipolar parents who had school-age children. And we collaborated on a grant that was successful with NIHR to launch a randomized control trial of this digital intervention. And the idea is to improve both child outcomes, but also obviously the confidence and competence of the parents in parenting and the mood stability of the parent. So that's one outcome of this related to this study. We also studied in adolescents potential psychological processes which might be amenable to psychotherapy and targets for therapy. and found that high avoidant coping and low self-esteem were important in predicting mood disorder in these high-risk kids. And collaborating with John Getty's group on remote capture daily ratings of affect, we were able to differentiate high risk from controls, and high risk who were in remission but previously had mood disorders from those who had yet not had mood disorders. And this was a feasibility pilot study, and was able to demonstrate that actually it was quite acceptable to the high-risk offspring to use self-monitoring. They were very compliant with it. They found it helpful. It was non-stigmatizing, and it could be a potential important way of early identification of mood problems. We've also worked with various colleagues in genetics labs, Gustavo Trecchi's lab at McGill and Albert Wong's lab at the U of T, and also with our colleagues in the Czech Republic, Thomas Hayek, who's now back in Canada, in imaging studies looking at structural and functional correlates of the clinical course. This is just one example showing preservation of a region of interest, the right inferior frontal gyrus. So in the high-risk kids, unaffected and affected, this structure seems to be preserved in terms of volume, whereas there's a loss of volume based on burden of illness much later in the course. Now, this is very different than what you might see, for example, in kids at risk for schizophrenia or early onset, first episode schizophrenia. We've looked at gene expression markers and differences both between high risk and controls, high risk and affected. This is using genes, a candidate gene approach, genes important for immune activation, thought to be a potential mediating pathway. And more recently, we've used whole genome sequencing in a linkage family study. And this is very recent, and we haven't published this yet. And we've got some very high LOD scores, the highest possible LOD scores on an area on chromosome 19 that we're following up. And then finally, coming back to AIM-3, our original question, can we improve risk for individual offspring who have a confirmed parent with bipolar disorder? Working again with Charlie Keenan-Stoneham at the University of Toronto, he used an interesting model with cure fraction, because survival models assume that we're all going to get the outcome, which is typically death at some point. And a cure fraction assumes that a proportion of the population will actually not have that outcome. So it's more appropriate for modeling illnesses like bipolar disorder. And we limited the model to only variables that a clinician would have on hand and would routinely collect in clinical practice. And then we replicated this model on the Swiss cohort in collaboration with Martin Pryzik's group. And we're able to show that while the confidence bands were much wider, so it's a less precise prediction in that population, but that could be due to all kinds of things. For example, those kids were recruited based on epidemiological principles rather than our highly selected families. We could still show good prediction from adolescence onward. And this is quite different from the first risk prediction model by Boris Biermauer's group, Daniela Hoffman, both in terms of the variables and also in terms of the approach taken. So they use Cox proportional hazards hazards model, which assumes, for example, that the hazard is proportional over time, which isn't necessarily the case. So that's the high-risk studies, and I hope I've given you kind of a tour through some of the major findings and how it's helped us understand. Of course, it raises more questions than it answers, but I think we've addressed those aims. And then more recently, I got interested in university student mental health. And the reason for that was because, first of all, there's an increasing demand straining university resources, and this is becoming really a major challenge for universities. And because at Queen's University, there were a number of student suicides, sadly. And so there was an interest from the Dean of Medicine at the time for medicine to get more involved in university student health and mental health, and really kind of bring an academic and lens as well as clinical support to those services. So why is this happening? So anecdotally, of course, we know that there's an increase in common mental health conditions, as I showed earlier, in young people this age. And we know that university enrollment is widening so that the university population is increasingly looking like the general population of young people. Also, university students are under unique stressors, and arguably even more so these days, even before the pandemic, because there's more competition, it's harder to get a first-class degree, uncertain career opportunities after graduation, and more students are actually financing their studies and having to work and balance work and study at the same time. Alongside those stresses, we know and appreciate more that the brain is still very much a work in progress. So the brain is undergoing accelerated growth and development. It's really perfectly pitched, highly sensitive to kind of absorb new knowledge and to consolidate new knowledge, but it's also very sensitive to risk exposures like binging on alcohol and using cannabis regularly. That, together with the fact that I think we've done a really good job of working on stigma and reducing stigma, so more students are more likely to come forward and advocate for themselves and their needs. And yet there's not really available student-friendly, student-tailored community mental health services. And we know this working as psychiatrists working in the hospitals and community services, that they're overburdened, that the threshold for admission is quite high in terms of severity and chronicity, and that doesn't really fit for the university student. So there's a question, well, is university suicide increasing? You know, when we get these spates of suicides happening at universities, and this is David Gunnell's work and Keith Houghton's work, looking at the higher education registry data showing that, yeah, there actually is an increase in university student suicides, males, of course, more than females, undergrads higher than postgrads, and second year undergrad higher than first year. So second year might be, you know, you want to prevent that happening in second year. That said, suicide rates in university students are still much lower than rates of young people of the same age in the general population. Interestingly, but not surprisingly, though, there's a seasonal variation. So here's the student suicide rates, much lower, of course, in the summer months and much higher during exam period. So there's been a number of white papers and sort of authoritative reports around what's going on, what do we need, what are the gaps, and they all actually conclude the same kinds of things. So that there's a need for large-scale, reliable longitudinal data. That's number one. Number two, there's all these different initiatives that are well-intended but not coordinated and not based on theory or theoretical models. So we need to pull that in, have a framework that's testable. We need to incorporate qualitative as well as quantitative data. And we need to use reliable state-of-the-art methods. And most importantly, too, we need to partner with students when we're doing this work. So not for us, without us kind of mantra. So that really, you know, gave birth to the Flourish. I had branded the high-risk study Flourish because most kids do not develop bipolar disorder. And then I sort of took the brand and created Flourish, student well-being research, because we wanted to have a positive spin. Most students are not going to develop mental illness, you know, mental disorders. That said, this is the peak period of risk, but also more students are going to develop distressing symptoms that can be impairing and get in their way academically. So how can we help but not, you know, make this into a mental health crisis kind of thing. So what we did was, in partnership with students, we developed an electronic survey study, because I started with very little money, so 45,000 Canadian dollars for 1 year. So I thought, what can I possibly do that's meaningful? So I thought, well, let's start a cohort and then build it and they'll come. So I thought maybe we could find more funding to continue. And in this survey, we were going to capture all incoming students to Queen's University at the very beginning of the year, and then we would follow up with them at the end of the year. We would use validated measures, and we would try to engage a broad representative sample, because those were all of the weaknesses in the data. And I was collaborating already in the high-risk study with colleagues at the University of Oxford, and I happened to be chatting with them about this, and they said, you know what, we're really interested in coming on board with that. So then we extended the survey to Oxford in the second year. So the survey basically looks at theoretically important risk factors, so early adversity, family factors, family history of mental illness, education of the parents, support, nurturing family functioning, but also personal health factors of the student, so previous history, physical health history, social competence and self-esteem, and then looks at more proximal factors, so locus of control, expectancy beliefs, behavior, exercise, substance use, and then maps onto outcomes measured using validated measures. So symptom levels using GAD-7 PHQ-9, as well as sleep condition indicator for sleep. And we also linked to the academic record to get objective measures of marks and any academic sanctions. What did we find? So time 1 is at entry to university, time 2 is at completion of university. We found quite high symptom levels that screen positive on these measures. So in other words, these aren't diagnoses, these are screen positives, so over the threshold. So we would want to ideally ask these students, how are you doing and what's going on? We wouldn't make a diagnosis at that point. So about 27% of students at entry screen positive for depressive symptoms, half of whom indicated functional impairment related to those symptoms. About a third of students screen positive for anxiety. Again, half of those who indicated functional impairment. And about 18% indicated a lifetime history of self-harm, suicidal thoughts, and suicide attempts. And this all increased at time 2 at completion of first year. The Oxford data was strikingly similar, really nothing different here. There was a lot of overlap, not surprisingly, in these mental health outcomes. So the same students would have multiple, screen positive for anxiety, depression, and suicidal thoughts or self-harm. Then we tested, this is with Charlie again, Stone, that we tested a model of, we wanted to hold constant or adjust for things we couldn't change. So this was all of the risk factors we knew to be important to mental health outcomes at completion of first year. And we looked at proximal risk factors measured at entry to university, which could be potentially modifiable by intervention. So we found that there was a significant contribution of sleep problems, substance use, lacking in exercise or study life balance, reduced social support, perceived low self-esteem, and high stress. And symptoms that were present, those who screened positive at time 1, there tended to be persistence at time 2. Now, we've had a number of students work on this data. This is actually a Canadian student who's rowing for Oxford here as a graduate student, and she looked at the association between certain psychological processes like perfectionism, self-esteem, external locus of control, and the association with insomnia, and all of those predicted for anxiety and depressive symptoms over the course of first year. We also looked at the question of what changed trajectories. So those who screened positive but screened negative and improved at the end of year, what was important, and those who screened negative but ended up developing symptoms over first year, what made the difference there? And we were able to show actually that university connectedness, so that membership with the university, I belong here, I feel like I'm valued here, I'm a part of this place. That was really important as an improvement factor, but also as a risk factor in the other direction. Also, drug use during school was an important predictor of onset of mental health problems. We are, of course, interested in heterogeneity or diversity, and this is a look at international students and how they fared compared to domestic students. And the worst of everyone were the domestic females who self-reported the highest level of mental health symptoms. And the international students weren't very much different between males and females in anxiety and depression. Where the international students were higher was in reported self-harm and attempted suicide attempts. Now, the other place where international students were struggling was in their academic performance in first year, even though they had very high marks coming in. And that could be an English as a second language issue, and it could also be related to a change in demands of learning, a change in learning approach. And so that was really helpful for the university to think about how to onboard these students in a more productive way. Since that initial 2018 to 2019 cohort 1 study at Queen's, we rolled it out at Oxford in 2019-2020, which of course was the onset of the pandemic. So we have pre-pandemic data in both Oxford and Queen's. And then we continued the study through the course of the pandemic. So it was quite lucky that it ended up being a digital tool rather than in person. And we did a supplementary survey in both Queen's and Oxford in the summer to look at the concerns the student had related to the pandemic, but also the impact that the pandemic was already being felt by the students. And not surprisingly, students thought this was a serious issue. They were more concerned about passing the illness on to somebody else inadvertently than their own selves. They were worried about missing out on university. They were worried very much about the impact on their careers. And when you looked at impact, they had a very negative, COVID had a very negative impact already in the summer on their social connectedness, so their ability to connect with other peers and to feel part of a social group. Also, they felt it had a negative impact on the quality of their university studies, their prospects for summer employment, their prospects for enriched learning opportunities such as exchanges and academic pursuits. And they had a very negative perception of remote learning. So all of this, and then of course, sort of also negative impact on ability to exercise and career aspirations. Now, this is looking at this first cohort longitudinally over the pandemic. Whoops, and you can see that, of course, females have higher rates, screen positive rates than males, but you can see that there was this increase over first year and then a dip and then an increase over second year. But during the, over the course of the pandemic, symptom levels stayed high. So there was an increase in sleep, anxiety, and depressive symptoms related to the pandemic. When we look at, now this is successive incoming cohorts. So the incoming cohort of 2018, first years in 2019, and first years in 2020, you can see again that incoming cohorts had higher symptom levels than previously to the pandemic. Interestingly, there was less alcohol consumption and less use of cannabis, and that's, of course, probably due to less opportunity to socialize. So just coming to the end now, I'm just going to check how much time I have. I was asked by a philanthropic agency, actually, could I write a grant that they would like to fund that would actually turn evidence into action, and that's what we called it. And that really gave rise to the development of a number of tools in collaboration with the University of Oxford that we're just piloting now in Canada. One was a fully credit-bearing, fully digitalized mental health literacy course that used state-of-the-art pedagogical techniques and also online learning, and really used self-reflection, problem solving, CBT techniques, and has a compassionate campus component that we feel is really exciting. And so far we've had very positive feedback from the students on that course. And we're doing a UK adaptation, actually working with the University of Edinburgh on that UK adaptation with Ruth Ann Baxter. We also modified a digital tool that was being used in the study of Oxford to provide a hosted digital well-being platform for students with access to apps with proven effectiveness in the general population, to see if that saved the need for more intensive services and was felt to be supported by the students. And then we also have a digitally enhanced care pathway using that same tool as a self-monitoring and student EMR or health passport to engage students in their own care and to titrate the intensity of care to the student need. Just quickly, we have very good data on the first 45 students going there. It was 50, but 5 ended up dropping the course before they started it. So we've shown a reduction in alcohol use and improvement in knowledge and emotional self-awareness through students having taken this course. And then when we compared this to the broader Flourish data from students who filled out the same measures but didn't take the course, we could see a trend towards improved sleep as well as reduction in substance use related to having taken the course. Finally, we have spun this into a UKRI successful grant with my colleagues at Exeter University and other universities to take this stepped approach across 6 UK universities. So these are a number of different stakeholders. We're hoping that the University of Edinburgh will join us in this venture as well. It's really cool because it takes a number of experts and expertise from various disciplines to bring to bear on the question, and it really has the Flourish survey running in the background to provide us with a comparator for these initiatives, which include the Compassionate Campus movement, the mental health literacy courses I mentioned, guided and unguided CBT that's digitalized and student tailored developed at Exeter, and then the digitalized enhanced care pathway. And we're looking at cross-cutting mechanisms so that we can compare the student journey through these initiatives, but we can also then understand what the active mechanisms might be. So with that, I'd like to stop. I've talked way too much, and acknowledge my collaborators, and thank you very much for your interest and attention.
That's fantastic, Anne. Thank you very much. That was an excellent talk. Really interesting data, and also interesting stuff around the interventions for students as well. I've got a couple of questions, but I'm happy to see if anyone else wants to either raise their hand or put something in the Q&A box, or I can even let you speak if you've got a question. So I'll give people a moment to think about that. So while people are thinking, Anne, can I ask you a little bit more about the high-risk cohort?
Yeah.
And a couple of questions I have are, firstly, you know, most of these kids of bipolar offspring don't develop bipolar, clearly, but how common is it for them to develop some kind of psychiatric disorder? You know, is that, you know, I'm thinking anxiety disorders, OCD, personality difficulties, alcohol use, you know, across the spectrum of psychiatric diagnoses, what's the kind of rate?
So we use cumulative index, cumulative incidence, sorry, it must be getting tired, cumulative incidence, as a way to kind of control for the variable observation period and variable age at last assessment, because the straight prevalence is hard to give with this dynamic cohort study. And these kids were from very select families, high penetrance, because the families were identified through genetic studies. So that's the other thing. So that said, as mentioned, you know, something like, I have to remember now, something like 15–20% developed diagnosable bipolar disorder, but many more developed something else, mostly depression or anxiety. So about 35% of the cohort had a lifetime anxiety disorder, and about similar had a history of diagnosable depressive disorder. Now, the cluster of the disorders, though, was very specific. So, for example, you wouldn't see OCD in an offspring of a classical manic depressive patient, more so than you would see in the general population. You would see OCD or other neurodevelopmental associated presentations in the offspring of the what I would call more atypical patients, what most people call psychotic spectrum bipolar disorder, or lithium non-responders. So they had more of the kind of broader spectrum psychopathology that you might expect to see in the children of schizophrenic parents.
Yeah, really interesting. And in terms of teasing that out a bit further, do you have sufficient numbers to look at, say, polygenic risk scores and how they might help carve up some of that heterogeneity? Is that something
actually
you've done?
I've been asking if anyone's interested in collaborating, because we actually sent our genetic samples to Switzerland, because I was looking for a collaborator to do exactly that kind of analysis. So Martin Pryzik's group is going to be combining their cohort with ours. But yeah, so I mean, there's lots of opportunity to take those genetic studies further, and to use, we would like to use polygenic risk scores in our risk calculator.
Sure.
For example. So if anyone's interested in collaborating on that, it's just really about bandwidth.
Yeah, and also numbers, I guess. So how many, you know, do you have? I guess you might not have DNA for all of the cohort.
Well, we have for most of it. Yeah, 300. Yeah, and then if there are other cohorts, you know, there.
Yeah, well, that's interesting. So that could be something to really get into, I think. And I was also struck with the prepubertal mania and the absence of that in Canada, anyway.
No, it's not in Canada. No, I always say it's the other way, that prepubertal mania, or the pediatric bipolar phenotype, is a made in USA construct. And I'll tell you what I think contributes to that. Number one, when you look at that speculation, those were kids that were referred to a tertiary care psychopharm clinic for ADHD. So those kids, most of them were male, most of them had severe ADHD and or pervasive developmental disorder. So of course they're going to have explosive temper and dysregulation, and so my hypothesis is probably part of the major problem. But that said, when you look at other people who have then since diagnosed it, of course they came up for a checklist for it. So it's kind of this, circular argument. We've made this checklist and we're calling it pediatric mania, so therefore it is pediatric mania. Yeah. But when you look at it, other places, other studies around the world have supported what I'm saying, which is, Anthony James looked at discharge rates in England and then across the Western world, and this is really an epidemic in the US. And yeah. Gay Carlson did a study with Richard Harrington, actually, before he passed away, and published it, looking at and was showing the same vignettes of kids. And then US versus EU English psychiatrists rate these vignettes. What do you think the diagnosis is? What's going on here? And the Americans would say, because that's the way they've been trained, well, this is pediatric mania. And the other psychiatrists would say, no, this is pervasive developmental disorder.
Yeah.
So, I mean, the same vignette. So obviously there's a cross-cultural difference in conceptualization. The other thing is in Boris Biermauer's study, for example, he recruited his parents through principally advertisement, and used structured or semi-structured interviewed by trained raters. So you're going to get a very different population, and yeah. Substance use in those families was extremely high. So these were chaotic families, yeah. who, and their diagnosis in the parent is not the same as parents who've been treated systematically with lithium, their whole diagnosis based on longitudinal clinical assessment and systematic treatment. So that's a very different.
Yeah, no, it's really interesting. Yeah, I'm going to let Ruth Ann ask a question, so I'll just bring her in. You can turn on your mic, Ruth Ann, and
hi there, can you hear me?
Yeah.
Hi, Ruth Ann.
Hi there. I was just going to ask, Anne, and I don't know that you have any data around this, but when you raised the importance of the student university, the connectedness, I just wondered, would that be as valuable if there were opportunities for students, primarily I'm thinking about those who are from out of town or international, to connect with the civic community? Or is it specific to connectedness with the institution?
The way that was, I think your question is the way that was asked, it's specifically connectedness to the university. Right. We also look, though, there's two other measures that come up. One is social support. So that's in your own local kind of friend group. So yeah. Peer connectedness. So we look at university membership, university inclusion, university connectedness, and then we look at sort of social connectedness, social supports, friends, relationships.
Super. Thank you.
Yeah, thank you.
Great. Any other questions from the floor? Everyone's being quite shy. And I guess you mentioned, Dan, that you'd be happy for people to follow this up.
Yeah.
Yeah. I can give out your email and people can get in touch. Because there's at least 2 or 3 things you've mentioned that I'd like to follow up with.
Sure.
After today. So, I mean, I guess as a final question, I was quite interested in what the students taking part in the surveys are coming in new to university, what do they get back in terms of support for filling in all these kind of questionnaires and all that monitoring?
So I should have mentioned, actually, the first 2 years of the survey study in Canada was a huge success. So we captured and replicated 58% of all incoming students across programs, which is like unheard of. And that was really down to the student engagement campaign led and designed by students. So the students told us what would work. And what we did was a number of things. We actually went to big 100 level classes, like Psych 100 is a very big lecture, and gave a sort of 1 or 2 minute talk about here's who we are, here's why we're doing that. It was a very kind of persuasive slogan, have your say, tell us, don't let us decide, you tell us what you need and engage with us in this conversation. We're not just here to take your data and run off. This is going to be an ongoing conversation. And so that really resonated with the students, and seeing their own sort of peers out there working, on the campaign. We also did hand out some things. So we had some very nicely designed laptop stickers and stress balls, and gave out candies and pizza. Pizza was huge. So you got a slice of pizza if you showed that you filled out the Flourish survey on your device. We also then gave, in the initial year, the Dean of Student Life offered to give a credit of $5 university dollars, which could be used at the bookstore or anything, to student accounts. And then she said, oh my God, I didn't realize so many students were going to join after this. So the next year, that was not offered. So what we ended up doing the next year was we gave a free drink voucher, which was donated by the school coffee shop.
Okay.
So students could have a free hot drink. And then we also had, if they filled out both surveys each year, we entered them for a draw for iPads, so 1 of 5 iPads.
Okay, excellent. So listen, Anne, that's been super interesting on many levels. I think more people will be watching this video when we put it on YouTube afterwards. So you'll probably get some queries after that. And you'll certainly be hearing from myself and Ruth Ann as well. But thank you very much for your talk.
My pleasure. Thank you very much for your interest and time.
And safe home when you travel back from Oxford to Canada. Hope
Yeah,
you make
thank
it.
you. Yeah, I hope my pre-flight COVID test is negative. Ah! Yeah.
Okay, Anne, all the
All right.
best.
Thank you very much. Merry Christmas, everyone. Happy holidays.
Cheers.